Good afternoon. Thank you for joining us today on this AGA webinar on Medicare's Incentive Payment Program, the Physician Quality Reporting System, or PQRS. I'm Joel Brill, the Chief Medical Officer for the AGA's Digestive Health Outcomes Registry, as well as the CPT and RUC Advisor for the AGA. The AGA for 2012 and beyond. You will also learn how to submit PQRS data quickly and easily via the AGA registry. To start, we're going to hear from Elizabeth Wolf, the AGA's Director of Regulatory Affairs, who will be providing history and background on PQRS. After that, I will discuss PQRS and how it affects you as gastroenterologists. All questions will be answered at the end of the webinar. If you have a question, please don't hesitate to type your question in the question pane on the screen. And with that, Beth, would you be kind enough to begin?
There's some problems with the audio, so again, my apologies. But thank you for joining us. And first, we'd like to begin the presentation by providing a brief history of the program. The Physician Quality Reporting Initiative was established by CMS to provide a financial incentive to physicians and other eligible professionals to satisfactorily report data on quality measures. The Tax Relief and Healthcare Act mandated the establishment of a Physician Quality Reporting Program, which included an incentive payment for eligible professionals. CMS named this program the Physician Quality Reporting Initiative, or PQRI. The Medicare, Medicaid, and SCHIP Extension Act authorized the continuation of PQRI for 2008, and the Medicare Improvements for Patients and Providers Act made PQRI a permanent program and increased incentive payments to 2% for 2009 and 2010. So the most recent changes to the program were made in the Affordable Care Act. The ACA renamed the program to Physician Quality Reporting System. It authorized incentives through 2014 and also required a penalty beginning in 2015 for eligible professionals who do not satisfactorily report. The ACA also established a value-based payment modifier that will provide differential payment to physicians based on the quality of care furnished as compared to cost. It's important to note that PQRS will be the basis for this value-based modifier. The modifier will be applied to certain physicians in 2015 and will eventually apply to all physicians by 2017. So based on comments CMS has made in the rules, it appears that this modifier will be applied to primary care and cardiology first. So other significant changes to the program include the establishment of a Physician Compare website where reporting and performance of PQRS measures will be publicly displayed. And it also includes provisions to ensure timely feedback to physicians in the establishment of an informal appeals process. This slide shows how the program has grown substantially since its inception. CMS continues to move toward a value-based purchasing model with the goal of tying Medicare payments to performance on quality measures rather than quantity and resources consumed. Although not on this slide, CMS just issued its final rule for the 2012 physician fee schedule, and in that rule, CMS finalized an additional 29 measures and 8 additional measures groups, one of which is the inflammatory bowel disease measures group. So as stated previously, PQRS will be moving from incentives to penalties rather quickly. Incentive payments will be available through 2014, and penalties will begin in 2015. So in the 2012 physician fee schedule final rule, CMS established calendar year 2013 as the reporting period for the 2015 payment adjustment. So this basically means that the measures submitted January 1, 2013 through December 31st, 2013 will determine the payment adjustment in 2015. Our next slide provides a brief summary of the success of those who have participated in PQRS. CMS publishes a report that summarizes the experience of eligible professionals in PQRS as well as trends in the program over time. The 2009 experience report is the most recent data available. So in 2009, over 119,000 physicians satisfactorily reported and received incentive payments with a total payout of $234 million. This averaged out to 1,956 per eligible professional and 18,525 per practice. registry submitted data for approximately 15% of participants. Eligible professionals participating through a registry were very likely to earn an incentive. So in fact, approximately 90% of professionals submitting measures through a registry received a bonus payment. The report is also broken down by specialty, so we're able to look at the gastroenterology specifically. So for GI, of the $234 million in total payouts, gastroenterology received approximately 0.97% of those payments, with an average incentive of $2,635 for those who satisfactorily reported. The table on this slide shows the percentage of eligible GIs earning an incentive payment, and it's broken down by reporting method. So you can see that for individual measures, 31% of GIs reporting through claims received incentives, while 97% reporting through registries received incentive payments. For measures groups, 17% of GIs reporting through claims received incentives, while 92% reporting through registries received incentive payments. And so at this time, I'll turn the presentation back over to Dr. Brill, who will discuss the specifics of PQRS.
Go ahead, Dr. Brill.
Folks, as you're probably aware, we are facing a healthcare cost crisis here in the United States. Over the past decade's time, there has been a significant, over 131% increase in health insurance premiums. Yet workers' earnings have only increased about 38%, and overall inflation has increased 28%. The result of that has been efforts both at a government as well as at a private insurance level to try to take action in order to try to reduce the cost of health care. Next slide, please. So one of the things that gastroenterologists and many other physicians are facing are efforts by health plans to try to implement value-based care. This can have a significant impact on patients as well as on doctors. Health plans are in the process of releasing information such as quality and also the costs for an individual physician, and that they are tying this information through the use of preferred networks, tiering, and other financial incentives to encourage patients to seek physicians who are deemed to be high-value, effective individuals. So, for example, a health plan or Medicare may determine that a physician has high quality and is cost efficient, and that individual will then have that physician will then have a $10 copayment to be seen. Another physician with the same quality but is more costly may be viewed as being an average value physician and may have a $30 copayment. And a physician who is determined by quality metrics as established by specialty societies to be not following the quality metrics and to be a high-cost provider may be deemed to be a low-value provider, and that individual could have a high copayment, which would constitute a financial disincentive for the patient to see that physician. Next slide, please. So why participate in PQRS? This is one of those unusual opportunities where there's actually money available. There are bonus dollars that are available now and will continue to be available through 2014. It's key to recognize, however, that if you don't participate in PQRS by 2013, you will be facing a penalty beginning in 2015. So if you take out nothing away from this other than this one statement, remember this: it's important to prepare your practice today in order to avoid penalties. So some of the questions that you might ask are, how does your practice operate, and are you ready for accountable care? Are there inconsistencies in how you treat patients? Is there variability in care for similar patients and similar conditions? And also, are you at risk because of variability in coding and documentation? Most importantly, participating in PQRS is part of participating in quality improvement activities. Next, please. Now, there's something that Medicare has put in place called the Maintenance of Certification Incentive Program. In order to be eligible for this bonus program, the physician has to practice in PQRS, and they have to participate in a Maintenance of Certification program for a year. And they have to successfully complete a qualified MOC program practice assessment in a year more frequently than is required to qualify or maintain your board certification. What does that mean? Well, let's say that you achieved your certification or recertification in 2009. So if you participated in the MOC program in 2012, that would be a practice assessment in a year more frequently than is required to qualify for or maintain your board certification. You're eligible, if you do this, for an additional 0.5% incentive payment through 2014. Next slide, please. Now, the AGA has developed quality improvement activities linked to maintenance of certification. Recently, the AGA developed a sedation patient safety practice improvement module, which has been approved by the American Board of Internal Medicine. This module provides Part 4 points towards the ABIM's Maintenance of Certification program. At this time, the AGA is also preparing an application to the ABIM for recognition of an additional quality initiative modules on hepatitis C and inflammatory bowel disease. So again, it's key to recognize that registry participation, along with MOC, equals incentive payments. Next slide, please. So what incentive payments are really on the table? Well, there's PQRS, there's maintenance of certification, there's e-prescribing, and there's an electronic health records incentive. And next slide. If you add all of these up, it actually represents a significant amount to practices. Now, for gastroenterology in the PQRS program, there are a number of measures that are currently and will be relevant. There are measure groups for hepatitis C, beginning in 2012, inflammatory bowel disease, and also a measure group currently available, the preventive care measure group. And there are individual measures around colonoscopy, body mass index or BMI, and assessing the patient for use of tobacco. Next slide, please. So over the next few minutes, we'll go over the PQRS measures and the reporting options. On this slide, what we've placed here are measures that fall into a measures group, which include the influenza and pneumococcal vaccination, colorectal cancer screening, BMI screening, preventive care and screening for unhealthy alcohol use, and tobacco use assessment. That constitutes a measures group. All of those measures, colonoscopy interval for patients with polyps, measure 185, constitutes claims measures that can be reported through PQRS. Next slide, please. Now, here are the hepatitis C measures, and as you can see, these measures can be reported as a measures group, as individual claims measures, or through a registry. It's important to note that Measure 83, confirmation of HCV viremia, is the only measure that can be reported through the registry, whereas the other measures, RNA testing before initiating treatment, HCV genotype prior to treatment, HCV antiviral treatment prescribed, RNA testing at week 12, counseling risk for alcohol consumption, contraceptive counseling prior to HCV therapy, as well as hepatitis A and B vaccination in hepatitis C patients can be reported, again, through the registry of the claims and the measures group methods. Next slide, please. And then here is the inflammatory bowel disease measures group, which can only be reported through a registry beginning in 2012. CMS released this in the final rule, which was posted on November the 1st. And the measures include assessment of inflammatory bowel disease activity and severity, assessment of IBD steroid-sparing therapy, bone loss assessment, influenza immunization, pneumococcal immunization, screening for latent tuberculosis before starting anti-TNF therapy, and hepatitis B assessment before anti-TNF therapy is started, as well as tobacco use cessation and screening, cessation intervention and screening. So what you'll note there is that while these constitute a measures group, which can only be reported through a registry, several of these measures also correspond with several of the preventive measures that we've seen previously. Next, please. So what are your options for reporting? Mark, could you please proceed, please? And I guess the question is, what can gastroenterologists, their practice managers, and their practices do to simplify your life? Well, it's become very apparent that Medicare is going to make it harder and harder to report individual claims as part of the PQRS program. The final rule has made it clear that Medicare intends to shift towards registry reporting, and as we just noted, the inflammatory bowel disease measures can be reported only by a registry. In addition, direct reporting using an electronic health record requires the specialties to develop measure sets. Next, please. So there are many options for reporting, and the problem is that each of these options differs slightly. Administrative data can be reported via claims or registry. Specific measures, rules, and specifications exist for each option, depending on whether the measure is a claims-only, EHR-only, registry-only, or a combination option. Next, please. If you report via claims, this relies on administrative data. It requires the practice to report a quality data code, such as a CPT Category 2 or a CMS G code. The problem is that there are different specifications than if one reports the measure as part of a measures group. Next, please. Here you can see why we're concerned about why claims reporting can lead to errors. This is a snapshot of the PQRS measure for hepatitis C RNA testing before initiating treatment. As you can see, it requires you to assess patients 18 years and older with a diagnosis of chronic hepatitis C who are receiving antiviral therapy for whom a quantitative HCV RNA testing was performed within 6 months. So it requires you to have the appropriate ICD-9 diagnosis, 070.54, a patient encounter during the reporting period, which is an E&M code, and it also requires you to report 2 CPT codes on the claims form, 3218F and 4150F, in order to submit the numerator option. I don't know about you, but that's a lot to remember in order to successfully report just this one measure. Next, please. So registry-based reporting options make things easier for practices. In an instance such as hepatitis C or inflammatory bowel disease, where greater than 3 measures apply, one can then look at the measures group on the right side of the slide, where one can either submit 1 or more measures group for 12 months or 1 or more measures group for a 6-month period. If you've been doing this for the whole year, then for a 12-month reporting of the measures group, for 30 or more applicable Medicare Part B fee-for-service patients from measures group, or you would have to submit data on greater than or equal to 80% of the applicable Medicare Part B fee-for-service patients with a minimum of 15 patients. If you're submitting a measures group for a 6-month period of time, such as the hepatitis C measures group for 2011, then you just need to submit data on greater than or equal to 80% of the applicable Medicare Part B fee-for-service patients for that measures group, which constitutes a minimum of 8 patients. On the other hand, if you wish to proceed during the individual measures option and you wanted to submit greater than or equal to 3 individual measures for the 6-month period of time, then you would have to submit data on equal to or greater than 80% of your applicable Medicare Part B fee-for-service patients. So clearly, the option that is the easiest for many physicians to complete now, if they haven't done so already, is to submit on a measures group for the 6-month period, and more specifically, for that minimum of 8 patients. Next slide, please. Well, there are many registries, but why are we talking about the AGA's Digestive Health Outcomes Registry? It was launched about 1.5 years ago's time, and the initial topics, inflammatory bowel disease, colorectal cancer prevention, and the PQRS hepatitis C measures group, align very, very nicely with where CMS and private payers are going in terms of quality measures reporting. Next, please. Now, as of about 6 months ago in March, there were about over 200 clinicians from 48 practices who are participating in the registry, and that number obviously continues to grow. Next, please. What does it mean to be a PQRS qualified registry? Well, you have to be a qualified registry in order to be able to submit quality data to Medicare. This means that the registry has undergone a thorough vetting process, and the AGA Digestive Health Outcomes Registry is the only gastroenterology-specific qualified registry that is able to submit data for 2011 PQRS reporting. Next, please. Now, as has been mentioned, PQRS reporting using the AGA registry in 2010, there were 44 eligible providers who submitted successfully. They reported in feedback that it was fast and simple, required 30 patients or less, and most importantly, feedback reports were provided immediately following the submission of data. Next, please. So what are your measure reporting options for 2011 if you choose to report in the hepatitis C measures? Well, as we said beforehand, if you started this process early in the year, over 12 months, you'd have to report 30 patients for a measure group, or a minimum of 15 patients, as long as that was 80% or greater for a measure group. If you haven't started yet, you do still have this 6-month option with a minimum of 8 patients, as long as that is 80% or greater for a measure group. The submission deadline is January 31st of 2012, which means you would need to join the AGA registry by January 13, 2012, in order to be able to qualify for and report on your 2011 PQRS bonus. Next, please. So here's a tip. ICD-9 diagnosis is critical to successful reporting. And one of the comments that we've received from CMS as to why people didn't get their bonus when they reported individual claims was that they used the wrong ICD-9 code. It's essential that you are aware of coding for chronic versus acute hepatitis C. Remember, 070.54 is chronic hepatitis C without mention of hepatocoma, and 070.51 is for acute hepatitis C without mention of hepatocoma. If you don't get the ICD-9 diagnosis right, then you won't get your bonus. Next slide, please. So why participate in a registry? Well, why participate in the AGA registry? Well, we're all went into healthcare to help patients. And we want to help you through the registry to achieve better performance measurement. This will help you to support patient-centered care. And we believe that in the future years, this will help physicians to obtain preferred participation in Medicare, both commercial fee-for-service as well as Medicare Advantage, Medicaid plans, commercial insurance plans such as Blues, Aetna, United, Humana, and the like, accountable care organizations, local networks such as IPAs and physician hospital organizations, as well as the exchanges, which are at this time still scheduled to become operational in 2014. Participation in the registry is critical because you'll be able to benchmark in your local community, across your region, or at a national level. We believe that these quality improvement activities will help physicians in the future to be able to meet regulatory requirements, and participating in a registry may also help you to participate in and perform clinical research. Next, please. So how can the registry help your practice? Well, it's clear from looking at the horizon that participation in a registry will lead to payment incentives. Those incentives could include an adjustment to your fee schedule or a bonus for pay for performance. As we've seen in some other specialties, registry participation may allow a payer to steer patients to physicians who demonstrate adherence with clinical guidelines. And we believe that that's pretty close to being on the horizon here for gastroenterology. Premium designation programs are tied to registry participation, and Medicare and commercial insurers are already beginning or already have begun public reporting of registry participation as one of their efforts to identify physicians who provide high quality, cost efficient, and collaborative care. Next, please. So if you want more information about this, feel free to visit www.agaregistry.org, or you can send an email to info@agaregistry.org. And with that, again, we apologize tremendously for the technical difficulties that we had at the beginning of this, but I think we're open for a few questions right now. Let me turn this back over to Command Central and questions.
Great. Thank you, Dr. Brill. At this time, if you have any questions, feel free to enter it in your chat box.
Question box.
Or excuse me, question box. And we will be happy to answer those questions. Okay, Dr. Brill, we have a question, and it is, how does one go about signing up?
Well, I think the easiest thing for folks to do would be to visit the website, www.agaregistry.org. And on that page, you'll find the information that you need, including a link to signing up for the registry, as well as further information, including information about what you need to do to participate from a technical manner, as well as the cost for participation.
Great. We also have an additional question. What is the cost?
There is a cost for AGA members. There is a slightly higher cost for physicians and others who are not AGA members, but they're also welcome to participate. And then there is an additional $150 cost for PQRS participation. If you add everything up in total, it's about $350 per physician per year for registry participation and PQRS reporting if you're an AGA member, and $500 if you're not.
Okay, great. And we have another question, too. It is, how does the AGA registry interact with EHRs that have registries as well?
Well, that's a great question. And one of the things that the AGA has been committed to doing has been to, first off, identify which electronic health records are being used in gastroenterology practices, both in community as well as in academic settings, and to see what we can do to directly link those EHRs into the registry. The first of those links is with GMed, and the latest version of GMed, GGastro, actually has direct registry reporting. And that means that the physician really doesn't have to do much of anything except turn the module on, see the patient, and GMed will then report that information directly into the AGA registry so that that can be reported on your behalf. The AGA has also worked with other EMRs, EHRs, to integrate information. We have a what's called as a middleware integrator called FigMD, and we've worked with NextGen, and we're in the process now of also beginning to work with Epic and others. And I'm also pleased to announce that the AGA is now beginning its integration with a number of EndoWriters, and that information will be forthcoming over the next few weeks and months' time. But that integration also will make it easy for those of you who use an EndoWriter in your office, your ASC, or your hospital system to also report information directly off of that EndoWriter that's applicable into the registry.
Okay, great. We also had another question, too, about the slides. We just wanted to let you all know that the slides will be posted to the website after Thanksgiving, and we'll send a link as soon as it's available. So let's see, we have another question as well. We are participating in meaningful use. Can we also participate in PQRS?
Well, I think there was a slide at the beginning of the slide that showed that, but yes, you can. There are incentive payments that continue to exist for PQRS for the next few years' time. But if you're not participating, as was mentioned beforehand, if you're not participating in PQRS by 2013, then penalties begin in subsequent years.
Great. We also have a question. Is there a template that AGA provides for those who don't use an EHR?
Yes. There is a reporting option available, which is web-based. It's actually pretty simple and easy. Most people who used it in the first go-round said that it added as much as perhaps 30 to 60 seconds at most in terms of the time necessary to report. It's all obviously, like anything else that we do in gastroenterology, we get better with practice, but that is available if you don't have an EHR or if you don't have an EHR that's currently linked into the registry.
We also have another question. Is it a requirement for all GIs to report on hepatitis C and inflammatory bowel disease through PQRS? If you don't report on these measures, will this cause payment reductions?
You know, gosh, that's a great question. I think the best way to answer that is the following. It's recognized that not every gastroenterologist sees patients with hepatitis C, and not every gastroenterologist sees patients with inflammatory bowel disease. So it's not a requirement that every physician does that. The dilemma that we have is that right now, those are the measures, along with Measure 185, the colonoscopy measure. And we don't have any other endoscopy measures in PQRS at this time. So certainly, the practice could decide to report on a hepatitis C measure set. We would encourage practices to report on the IBD measure sets, obviously. But even if a practice just reported on Measure 185 and then identified some of the other preventive service measures, that might be a way to work your way into PQRS reporting as well.
Okay. We also have another question. Does it have to be an active hepatitis C encounter in 2011, or management of symptoms diagnosed previously?
Well, I think the best way to answer that is that you've got to go back and look at how the measure set is developed and the key to that measure set. Remember, in the way that that we went over a few moments ago, remember that key thing. It's beginning. The measures are before the beginning of the treatment of that patient with acute hepatitis C. Now, there is further information that is available on that, both on the CMS website under www.cms.gov/PQRS, and there is information, I believe, available on the AGA website as well.
Okay, and we also have a question, does the registry work with Endosoft or Allscripts?
Well, as mentioned beforehand, one of the things that we have are two options. Allscripts is an electronic health record, and our system integrator, FigMD, works with Allscripts and other EHRs. Endosoft has both a, if I'm not mistaken, has both a EHR module and they also have an EndoWriter as well. And so, as mentioned, the FigMD option is available on the EHR side, and that on the EndoWriter side, the AGA is in the process of integrating with a number of EndoWriters. I don't have the exact list in front of me right now, but I'm sure that the AGA will be happy to provide a list of those EndoWriters that we've integrated in as that integration goes forward and gets completed over the coming weeks and months.
Great, that's very helpful. We also have another question, and this is about specific measures. So have any gastroenterologists in the U.S. received reimbursement based on PQRS submission of measures 113, 125, and 185?
Well, I think as we said beforehand, 185 is the one that gastroenterologists most commonly reported on. I believe, having looked but not recently at the information, that there have been gastroenterologists who have reported on 113. That is the colorectal cancer screening measure. And also gastroenterologists have reported on measure one and been paid for 128, which is the BMI measure. That data is available from CMS, and it's broken down based on the NPI reported specialty for that physician, for physicians generally.
Okay, and we have another question. Will the 2012 biopsy follow-up measure be relevant for gastroenterologists?
That was a measure, I think you're referring to actually the Barrett's esophagus measure, and that was a measure that was proposed by the pathologist. And that appears from everything that we've seen so far to really be focused on the pathologist, not the gastroenterologist reporting that measure.
Okay, we also have a question. Is it too late to report on the full year for the hepatitis C measures group via the registry? I have at least 100 hepatitis C patients, excuse me.
Well, I'll defer to your I'll defer to the AGA staff to better answer that question, but I will say the following. Whether you report on a full year or on a half year, it doesn't affect your bonus potential for 2011. So if you've got those patients and you haven't reported yet, this is certainly your opportunity to get in, get reported, get reporting now, and get that bonus money that otherwise would be given to someone else.
Yes, Joe, I don't think we have anything to add at this time. I mean, that's the bottom line, is that, you can certainly go ahead and do that we'll find that information out and follow up and get back with you direct, the person who inquired directly. We do have that information.
Okay, great. So we have another question. Can I report the hepatitis C measures via the registry and as individual claims, and is there any advantage to doing so?
I think the major issue which we try to highlight is that claims reporting has a lot of opportunity for error, and that not just the fact that it's error. If you mess it up, you just don't get paid. There was a slide that I believe Beth, you showed this earlier, that showed the significant difference in those who were reporting through a registry. So I'm, like most other people, looking for the easiest and most efficient method for getting it done and getting it right. And I think that given the complexities we showed with just one of those hepatitis C measures, and all the various elements you have to submit on the claim form just to get that one measure right, it would just seem that registry reporting is so much easier.
Thanks, Joel. We do have some additional information from our AGA registry support staff, and they have clarified that, in fact, it is not too late to report for the full year. So via the registry, folks can, in fact, if they have not already reported on those patients through the registry yet, they can certainly go ahead and do that. There will probably be some details around linking those up to claims. So again, we will put some additional detail on the website in a way that's a little more clear for folks to understand that. But that opportunity does appear to be there.
Okay, great. Thanks, Debbie. We have time for one more question. Let's see. Is AGA working on getting GPRO 2 certification?
Debbie, I think I'm going to defer to you on that one, because I think, if I'm not mistaken, Medicare changed some of the rules next year, the final rule regarding GPRO 1 and GPRO 2 options.
Right. And we have not really been pursuing that. We certainly could look into that again and see if that's something that makes sense for us, and how we could accomplish that and get more information out to members. But at this time, that's not something that we are working on directly. But we'll follow up again in our Q&As that will be posted, so that we can provide whatever additional information we have in the next week or so for folks.
Okay, great. So we just wanted to say thank you for participating, and if you had any questions that were not answered today, that we will be getting in touch with you, and we'll follow up with you to make sure that those questions are answered. So Dr. Brill, do you have any final thoughts?
Thank you, everybody, for participating. Apologize for the